Welcome to Therapeutics, and in this block, we're going to start our cardiovascular medicine with hypertension. There's a fair amount of drugs in our toolbox for hypertension, and some of these medicines will come back again to talk about their use in other cardiovascular disease states, particularly in heart failure. So you'll kind of see a resurgence of us discussing some of these same meds later on in the cardiovascular therapeutics block. We're going to focus on hypertension a bit, use some of the national guidelines for hypertension, recognizing with other national guidelines and goals, different organizations may have different sort of sets of goals or ideas about that. And it's been a little controversial in the last 4 or 5 years about what different organizations, how they approach hypertension, what they recommend for goals for blood pressure control, and how they go about achieving those ends. And so I'll try to navigate through some of that with you. But if you really also focus on what are the agents we use, particularly on what are the first line agents we use in hypertension and know those categories reasonably well, then I think you'll be well positioned to how to apply this in practice. So let's first focus on hypertension itself. Most of what I am providing here for a framework of context of these drugs and when they're used and how we approach hypertension comes from the American Heart Association and their updated recommendations as of 2019. And so I'm using the AHA, not that the AHA is the only source for recommendations, and I'll allude to some other issues with European studies. But I think the AHA has done a reasonably good job at simplifying hypertension management and providing resources to both clinicians and to patients on how to approach hypertension, how to manage hypertension in ways not to get into trouble. And so a lot of these slides or images come right from the American Heart Association, and I encourage you to sort of go to their website to read more about it. So one of the issues I think as a clinician is to make sure that you're getting an accurate blood pressure reading, and so you want to make sure that patients are positioned well, that you've got the appropriate blood pressure measuring device, it's calibrated appropriately, the right size cuff is used, and then you're sort of going through the patient is resting, that they haven't just run into an appointment up a flight of stairs and then you're taking their blood pressure right away. So you want to get multiple blood pressures and then use an average of those on 2 different occasions at least. Historically, we say 3 different blood pressures, but maybe 2 is enough with an average. And sort of I'm assuming in the clinical medicine block and in your labs, you're getting all of the issues about how to get an accurate blood pressure assessment. There are multiple different charts for goals for blood pressure from different organizations, and they sometimes conflict. And even within the AHA's own documentation and their own provisions, you'll find that their recommended blood pressures may change based on certain comorbidities or other circumstances. So we're really looking, and the AHA's nomenclature has recently changed, so that we're looking at a normal blood pressure is 120/80 or less. And that anything above that is at the very least elevated, and we call it high blood pressure or hypertension at 130 above 130/80 to 89 or so. And then we look at stage 2 and hypertensive crisis listed here. The numbers are kind of listed here. There are sort of 2 things that was sort of looked. One is the definition of high blood pressure, and the second thing is at what blood pressure point do we start treating that high blood pressure? So keep in mind, one is our blood pressure and what we call it hypertension, and then the second set of numbers might be for which patients do we actually add drug therapy on board. Their overall schema for blood pressure approaches in this graphic. I'll go through this moderately quickly here, and then we'll go through it in depth. They list more or less what their blood pressure's goals are across the type or what definitions are, and then as you go down, what you need to do non-pharmacologically or pharmacologically in each of these circumstances. and we'll sort of walk through some of those in a bit. In the lower left-hand corner, they have both optimal lifestyle and non-pharmacologic approaches. We'll go through those in a minute. And on the right-hand side, their checklist, which we'll also go through. So the lifestyle habits they're recommending, and this is consistent with pretty much any international and national organization or guidelines for blood pressure, is healthy diet, weight loss, physical activity, stop smoking, alcohol in moderation, and then related to all of those lifestyle habits, if folks are having issues they're not there, then looking at weight loss for folks who are overweight. Healthy diet that is classically DASH, low sodium, and maybe a little higher in potassium. Typically, we'll talk more about potassium and electrolyte management at another point in the year, but we typically look for folks, particularly who have any cardiovascular risk, of keeping their potassium in the normal range and sometimes even above serum potassium of 4. We also want to look at increased physical activity with an exercise program and limiting alcohol intake. The reassessment list at every visit is measuring. So as we look at the blood pressure thresholds, we're trying to get everybody in the far left-hand corner, blood pressure below 120/80. You want to continue with that patient, say, here are the lifestyle things, you're doing them, keep doing them. If you're not doing them, you want to kind of add that on, and at your next physical, let's just reassess your blood pressure, or at least make sure that your blood pressure gets assessed for an adult every year. And again, these are all guidelines for adults. The second side is when somebody has elevated blood pressure. We're going to look at adding on all of the lifestyle and non-pharmacologic approaches we can do, and then reassess them in 3 to 6 months and see where they are. If they have other comorbidities and they're in that elevated blood pressure group, we may look, and when we talk about the drugs, we may look at whether or not we may even want to look at adding, for example, an ACE inhibitor or an ARB on board, for example, if they're diabetic or have early renal insufficiency or spilling a little albumin in the urine with diabetes. Even if they're in that elevated blood pressure group where we normally wouldn't consider treating, you might consider a low dose of an ACE or an ARB in that situation. We'll talk more about that in a little bit. For the stage 1 hypertension group, we're going to look at getting the clinical atherosclerotic assessment risk estimator for the 10-year cardiovascular risk. And we're going to talk about that in a couple of minutes. We're going to ask that you download an app or have access to an app that is going to help you predict a atherosclerotic risk for 10-year risk. That is going to be a standard of care for most patients now who are adults, particularly with hypertension or other comorbidities that pose cardiovascular risk for them. If that 10-year calculator is below 10%, then we're going to do non-pharmacologic intervention and reassess them before we start pharmacologic intervention. If it is greater than 10, we're going to do pharmacologic intervention as well as non-pharmacologic intervention and continue to assess them on a regular basis. And then if they have stage 2 hypertension, we're going to do both the non-pharmacologic intervention and the pharmacologic intervention and continually assess people as well. Okay, so really stage 1 and stage 2 hypertension, we're doing all the non-drug things, but we're going to layer on drugs, and we'll talk about when we layer on those drugs and which drugs make sense for which patients. So they have, the AHA has a hypertension guideline toolkit. It's online. I encourage you to sort of, it's a great thing to download. There are both images that make it easier as a clinician to kind of know what to do, and some of them can be shared with patients that help as well. So as a reminder in hypertension of why it is that we manage hypertension, why blood pressure is considered the silent killer, is because of this domino effect of increasing risks for coronary heart disease, for stroke, for heart failure, for kidney disease, and for vision loss. All of these are problematic. And then As we will talk about, or we talk about an endocrine block, adding hypertension to diabetes really is kind of a dual, uh, you know, increase the risk for all of these things happening to a greater extent with diabetes and hypertension compared to just hypertension alone. So all of the sort of comorbid or other modifiable and unmodifiable risk factors that are related to what those target organ damage situations are listed on this chart. So the modifiable risk factors, the things that you're doing smoking cessation, avoiding secondhand smoke. You're doing what you can to get glycemic control or preventing diabetes in a patient. You're going to manage their lipids. We'll talk about lipids in a future block here. You're going to manage obesity and weight loss, typically not with drugs. Typically, we're going to do that with lifestyle changes. We're also going to look at increasing physical activity and addressing dietary issues. Those are all modifiable related to hypertension and coronary risks, so we're going to sort of pay attention to that. The other issues we're going to look at are the things that are fixed factors you can't do much about, but they're going to up the ante, and so we're going to be more aggressive for hypertension control. Our goals may be more aggressive in patients with existing kidney disease, with a family history of hypertension or older patients, socioeconomic status, male sex, sleep apnea, psychosocial stresses all sort of play into cardiovascular and hypertension risk, and those may influence your decision of how aggressive you are in their blood pressure control. Keep in mind that half the patients you're going to see as adults have high blood pressure, half of them, and many of them are not well controlled. We look at if we control blood pressure, for every 10 millimeters of mercury reduction in systolic pressure, we can reduce coronary heart disease risk by 17%, stroke risk by 27%, and heart failure by 28%. Those are really great numbers, and that's not a big drop in blood pressure. So really these more aggressive numbers, and basically depends on what study you look at, what cohort you're looking at, but overall for every 10 millimeter drop in systolic pressure, you achieve about a 20% reduction in these comorbid states. So, an important thing to consider, and also an important thing to explain to patients why it's important to control their blood pressure. In 2018-19, the new categories by the AHA for blood pressure categories are sort of listed here. We sort of reiterated that. But keep in mind as we talk about these, the set points for when we're going to treat may be subtly different from these numbers. These are just the categories of hypertension, not necessarily the points at which we always treat. The prevalence of hypertension, overall about 46% of patients, and we can see that the prevalence is higher in older patients, and the prevalence might be higher in certain race ethnicity situations, and also males versus females. So all of these are variables we can, the bottom line is hypertension is widely prevalent, and so that's going to be something you're dealing with for all patients, inpatient, outpatient, no matter where you practice. One of the things that are important to sort of share with patients are things that can raise blood pressure, and so we're going to say pay attention to things to avoid illicit drugs. You want to be careful about some herbal supplements that can make matters worse. This is particularly true for some of the herbal supplements that patients use for weight loss that are somewhat stimulating. And then high tyramine containing foods if folks are also on antidepressants particularly, or another MAO inhibitor. They also want to limit alcohol intake and caffeine intake and avoid cough and cold medicines with decongestants. You want to look at risk-benefit of nonsteroidals, amphetamines, and anything else that is known to cause an elevation in blood pressure. For estrogen can be a problem, and hormonal contraception can also be a problem, and we see that for a number of people as well. The thresholds for treating blood pressure for the majority of patients, and we're going to look at modifiers in a little bit, but in general, if your atherosclerotic risk factor is 10% or higher, or you've got already some clinical coronary vascular disease, we want your blood pressure, and we're going to treat your blood pressure if it's anything above 130/80. If your coronary risk factor is less than 10%, then the global blood pressure goal is keep it less than 140/90 before we start treating. These are the thresholds for treating elevated blood pressure, but we're going to look at some modifiers in a little bit. Okay, so let's look at the first and some of the second line drugs, pharmacotherapy, antihypertensive therapy that the AHA recommends. And we're going to use this as our template for how we're going to roll out our discussion of each of these drugs. The first line drugs include either thiazide diuretics, ACE inhibitors, ARBs, angiotensin receptor blockers, or calcium channel blockers, particularly the dihydropyridines. And the AHA doesn't recommend these in any particular order. At least, it's not like thiazides are always first, but we'll come back and talk about in certain subset patients where some agents are preferred over others. For example, if you've got a person who has African American ancestry or is black, they may not genetically respond as well to an ACE or an ARB, and so in that population we may recommend thiazides and calcium channel blockers as our first line therapy. If a patient has diabetes, we know that ACEs and ARBs have a better track record at preserving renal function long term in those patients than the thiazides or calcium channel blockers. So for diabetics, we're going to probably use the ACEs or the ARBs first if there's not a contraindication. So we'll kind of walk through each of those as we go along. Let's not focus on the second line agents yet. We'll get to those in a little bit. So per the AHA, let's look at the first line therapies. Again, thiazide diuretics, ACEs, ARBs, or calcium channel blockers. Let's first go through the thiazide diuretics. Now there's lots of different diuretics, so we'll briefly talk about them all, but then we'll come back and differentiate the diuretics both here and as second line agents. We'll finish up our discussion of diuretics. So diuretics as a group can be used for hypertension. We often also use them for edema and in heart failure. They fall into 5 broad groupings. And in this group, we're only going to talk about the second group listed here, the thiazides, because these are really the only ones that are first-line therapy for hypertension. But we have the loop diuretics like furosemide or Lasix. Those are going to be very commonly first-line in edema and heart failure. The thiazides, you could use those in heart failure and edema. We don't often because they're not as aggressive at getting fluid off, but they seem to have more of an effect for vasodilation and are better and have a better track record in hypertension. And the thiazides are what we're going to focus on here. The remaining diuretics we'll talk about as second-line agents in hypertension because these other agents, potassium-sparing agents, osmotics, and carbonic anhydrase inhibitors, each have a role in other comorbid states with or without hypertension. We'll talk about that in a little bit. There are a number of the thiazides that are on the market. The two I want you to, well, actually all 4 of these, I guess you should probably have familiarity with. The one that's historically been used the most is hydrochlorothiazide. It's available for a long time. It's relatively cheap, and that's true. The one at the bottom, metolazone, is used as a thiazide diuretic, but usually only as a low dose in combination with a loop diuretic in patients who are not responsive as we would like. So we often will limit metolazone to heart failure patients who need a lot of fluid coming off, and they're not responding to their furosemide, their loop diuretic, as well as would like. We'll talk more about that in heart failure a bit. But hydrochlorothiazide is probably the one you'll see most often. Of them, though, I'll say the one I'm going to point to that probably seriously has more data for its use over the years is clothalidone. Clothalidone is the original thiazide diuretic that probably had more of the hypertension studies done 30 plus years ago that demonstrated benefit effect over hydrochlorothiazide. So even though hydrochlorothiazide is still very commonly used by popularity, clothalidone actually may be by some yardsticks, I guess, by some earlier data, the thiazide that was better studied in hypertension. Where the thiazides work, they work in the distal tubule, uh, and so they really work there. They're not as aggressive at getting fluid off, but they also seem to have some sort of residual or anecdotal, not anecdotal, but ancillary effects on blood vasculature as well. So the thiazides work to affect the reabsorption of sodium and chloride in the early segment of the distal tubule. We primarily use them for hypertension. Now, where they don't work, where thiazides don't work, is if somebody's renal function is poor. If their creatinine clearance is below 30 mils per minute, thiazides don't really work that well. So if they're in renal failure or, sort of considerable advanced renal insufficiency, creatinine clearance less than 30, thiazides are really not effective. We probably wouldn't consider them. What do we watch for with thiazides? Dehydration and acute kidney injury. We'll come back and talk about this, but anything else that poses reduced perfusion to the kidney, we worry about, and folks can run into trouble with any diuretic, thiazide included. We'd worry about hypotension, which could be secondary to dehydration. That could also cause or risk for acute kidney injury. We worry about electrolyte imbalances, particularly low potassium, also maybe hyponatremia, hypomagnesemia. And the other thing with gout, with thiazides, is the risk for gout, because thiazides often elevate uric acid levels. There are also lots of interactions we'd consider or worry about, but the biggest important ones are the interaction with lithium and also patients who have gout, elevated uric acids with thiazides. I alluded to, there are more than the 4 thiazide diuretics we alluded to earlier, but frankly, other than the 3 I alluded to more, hydrochlorothiazide, clothalidone, and metolazone, these others you won't really see all that often. Okay, so those are the thiazide diuretics, and they are considered by AHA a first-line treatment for hypertension. They are more commonly used in folks who genetically may not respond to an ACE or an ARB, or for whom that might not be a good choice because they've had a contraindication to them. We're going to talk about the ACE and ARBs, though, because those, for most patients, are our first-line therapy. Okay, let's spend some time on some of the other first-line agents. First of all, let's sort of review angiotensin and how that's involved in blood pressure management and other conditions. So this graphic, it's a fairly busy graphic, but let's start and think about how angiotensin relates to renin. And typically, angiotensinogen is chemically converted in the presence of renin to angiotensin 1. And then there's an enzyme that converts angiotensin 1 to angiotensin 2 that's ultimately angiotensin 2, when it's stimulated, will cause aldosterone secretion, which triggers salt and water accumulation, loss of potassium, and elevates blood pressure by fluid retention. Also, we see angiotensin 2 causing some renal vasoconstriction and affecting glomerular filtration rate if it's overly aggressive. And so that can be improved with a blocker somehow in this process. And also angiotensin 2 directly causes vasoconstriction. So if we gave something that interfered with renin, we'd see and there's a renin antagonist we could consider using, although clinically in practice we don't really do that. But we'll see that factors that will reduce that is sort of normal homeostasis improvement, which would impact on renin. What we will use clinically are either drugs that block the angiotensin converting enzyme. There are the ACE inhibitors, the angiotensin converting enzyme inhibitors, or drugs that are antagonists in angiotensin 2. And so those are really the two broad groupings of drugs. They work sort of as a 1-2 punch in this system. Well, you can imagine, when is it going to be helpful to blunt this system? either by blunting the amount of angiotensin II or blunting the receptor where angiotensin II binds. That's going to reduce blood pressure, and it's going to overall affect renal blood flow. And so they're going to be agents that are going to be helpful in hypertension. They're going to be agents that may be beneficial in preserving renal function in folks at risk, although we'll talk a little bit about the renal pros and cons with ACEs and ARBs. And they're going to reduce the aldosterone and salt and water accumulation, which is also problematic in patients with heart failure. So ACEs and ARBs are going to be really a first-line therapy not only for hypertension, but hypertension in diabetics who have a risk for renal insufficiency long-term, and for patients who have heart failure because of their ability to blunt salt and water accumulation. So all great things to see. There are a number of macro and microvascular issues that also happen when you sort of augment this angiotensin-renin system. Macrovascular changes related to vasoconstriction and stimulation of aldosterone, among other things, and salt and water effects. There are also microvascular changes that are also seen that are not helpful. So our choices here for therapeutically blunting the system are so sort of in a nutshell, you can well imagine if we inhibit this renin-angiotensin-aldosterone system, we'll see benefits in both renal and cardiovascular situations. And these are all really helpful for anybody who has a risk for cardiovascular disease. So I won't sort of belabor this, go through this chart in detail, but just know there are lots of benefits for doing this. We also will see, in addition to that, for folks who have diabetes, we see that this kind of effects on macro and microvascular systems in patients, particularly with diabetes, makes ACEs and ARBs really a first-line therapy. And we see that over time, there is this vascular remodeling that happens if the system remains unchecked. If the renin-angiotensin-aldosterone system continues to be sort of hyperactive in place with mechanical issues and oxidative stress, we see functional and structural changes that ultimately only make matters worse, not better over time. So we're going to look at really blunting the effect either with a renin inhibitor, which clinically, again, we don't really use, but more commonly either an ACE inhibitor or an ARB. And those are going to be really helpful in our modalities. So that is a context. Let's first look at the older, longer around angiotensin converting enzyme inhibitors. The first angiotensin converting enzyme inhibitor was captopril. And it can be used for hypertension and heart failure. The early data was good. It's also used for diabetic nephropathy. The issue, though, with captopril is that it doesn't have a very long duration of action, and it's interfered with food. And so even though it's available, it's just not pragmatic because you have to dose it frequently, and you have to worry about meals or no meals. And so captopril, while it was the first ACE inhibitor, it's pretty rarely used now. I think the only settings where you may see captopril used are usually pediatric settings where there's more data in pediatrics than there is for the other ACE inhibitors in that population. There are lots of different ACE inhibitors on the market. Really, the couple that you'll see used most often are enalapril, lisinopril, and then maybe you might see one of the others here. Ramipril, sometimes. Ramipril was the agent that was more often used early on in heart failure studies, for example. But most of these agents can be dosed, particularly lisinopril can be dosed, and enalapril can be dosed once a day because the duration of action is long enough. And so that's pretty routinely used. These are pretty routinely used in practice. So the downside of ACE inhibitors, first of all, they're teratogenic. So we would not use them in a woman of childbearing age or a woman who's going to become pregnant. If you have a compelling reason to use an ACE inhibitor over something else in a woman of childbearing age, you need to make sure they know they have adequate protection against becoming pregnant or They will switch therapy when they want to become pregnant. And keep in mind that the risk may be in the first trimester before a woman knows she's pregnant. So in general, women of childbearing age, we do not use ACE inhibitors. There's also a sort of a benefit and a risk with ACE inhibitor therapy and ARBs for that matter, receptor blockers, in patients with renal insufficiency. And we use them, but we use them carefully. Here's the sort of bottom line, and we'll come back and talk about this more in the nephrology block later in the year. But ACEs and ARBs are associated with maintaining an adequate head pressure in the glomerulus. And if we overdo that, overshoot that with an ACE or an ARB, we can actually reduce renal blood flow too much, and what we end up with is acute kidney injury, worsening than where they are. And so we pay attention to that, but most folks do quite well with an ACE or an ARB. We start them off at a low dose, and we make sure there's not other nephrotoxic drugs on board, and their blood pressure's adequate, not low, and they're adequately hydrated. So all of those are things that sort of have to be in alignment here. So the adverse effects we've talked about there, we've talked about a couple of them. We've talked about pregnancy and fetal injury risk, and we talked about the potential risk for kidney injury in the short term. The real people who are going to have the biggest risk for renal injury are folks who have renal artery stenosis. So two contraindications we've already talked about here. One is pregnancy or potential to become pregnant. Second is anybody with renal artery stenosis. Both of those can be really problematic and are contraindications for ACEs and ARBs. A third one is a rare IgE-mediated reaction, angioedema. So anybody who has angioedema to an ACE or an ARB, we typically avoid ACEs and ARBs from that point forward. We're really careful about that. So that's the third one. The other things that you will see with an ACE or an ARB, you might see a productive cough, although sometimes we don't even want to tell a patient about this because the power of suggestion is almost like the power of suggestion of a yawn, that they will develop a cough. We also may see hyperkalemia, elevated potassium, so we need to kind of keep an eye out for that in some patients, and keep an eye on their kidney function and their fluid balance early on when we start therapy. Other things that are more rare are rashes, neutropenia, and then a sense of distorted metallic taste, and that might be because the ACE or the ARB is secreted in saliva. But usually the benefits of ACE inhibitors, as long as it's not a pregnant woman or a woman of childbearing age and angioedema, other than those two issues, we can use ACE inhibitors with clear benefit for folks with comorbidities and hypertension, particularly diabetes and hypertension. The angiotensin receptor blockers are almost identical as a group with maybe subtly more beneficial side effects, and we'll talk about those. The angiotensin receptor blockers are losartan is sort of the one we think of as the prototype for the class. And these work at just farther down the line at the angiotensin 2 receptor. And we're going to use them for hypertension. We're going to use them for heart failure, diabetes. Really, any place we're going to use an ACE inhibitor, we could use a receptor blocker. They're very similar for side effects, except two benefits here. They don't seem to cause the ACE cough that happens, that dry cough with an ACE inhibitor, and they may be lower risk for angioedema. So there are some clinicians, when choosing between an ACE or an ARB, they may pick an ARB because there's less risk for angioedema and there's no cough. And because many of these drugs have become generically available in the last couple of years, they're almost as cheap as ACE inhibitors too. So an angiotensin receptor blocker, they are beginning to replace first line the ACE inhibitors, but you pick one or another. But they pose the same risk as a class with pregnancy and any hypersensitivity, particularly angioedema. There are a number of ARBs on the market. Here are some of them. Candesartan is a common one. Irbesartan is a common one, and losartan are the sort of the big three that I've seen. Valsartan, the fourth one. These are largely interchangeable, but clinically the advantage is to go with something that's longer acting, that's a once-a-day dosing. And so many clinicians might want to go with irbesartan or olmesartan as opposed to using ones that have to be dosed maybe twice a day. So the regimens do allow for many of these things once a day dosing, but sometimes some of them require more than twice a day dosing because of a shorter half-life, excuse me. And then there are lots of metabolites, some of which are pharmacologically active. Don't worry about these, but I think I share with you once a semester I have to show you a chemical structure or I lose my pharmacy license. That's a joke. Okay. So the ACEs and ARBs, as we alluded to, because of their macro and microvascular changes, are really beneficial in patients with diabetes and heart failure and renal disease. And so I'm going to go through these slides quickly. But when we have those as comorbidities, really ACEs and ARBs float right to the top as our first-line choice for hypertension. So lots of issues as well as all of the things related to renal function and diabetes that may also affect insulin sensitivity and glucose transport. This data is not really, solid clinically, but I think to say that anything offers an advantage in a diabetic patient, that's a great thing. So ACEs and ARBs may actually lower the risk for developing diabetes. And so for folks who are pre-diabetic in metabolic syndrome, even if their blood pressure is kind of borderline or an ACE or an ARB, makes sense to consider using or adding on board. For folks in heart failure with diabetes, all the more reason why an ACE or an ARB makes sense for lots of things, for lots of reasons here, lots of potential mechanisms here. And we'll see that in diastolic heart failure and diabetes, we're going to probably do multiple things, but an ACE or an ARB is going to be a mainstay of that approach. We'll talk more about heart failure in general in a couple of weeks. There's also a number of studies that have looked at the benefit of ACEs and ARBs in non-insulin dependent diabetes mellitus and overall some benefits associated with the development of renal disease. And so we see that we really forestall renal involvement in diabetics when we use an ACE or an ARB. The issue, though, we allude to is when we start somebody on an ACE or an ARB, we do it with a low dose. We make sure they're reasonably hydrated and they're on other nephrotoxic drugs on board. Because sometimes you can see a real bump in the serum creatinine and acute renal injury with an ACE or an ARB when we start it. So we do that carefully, and we'll reinforce this again in the renal block later on in the year. We also watch for hyperkalemia as well as renal function. And who are the folks who are going to be more problematic for this to happen? Folks who already have renal disease, folks with diabetes, with volume depletion, older patients, and then folks who are on drugs that can predispose to this renal injury, particularly the non-steroidal anti-inflammatory agents or diuretics, anything that is going to predispose to poor renal perfusion. There are also some drug interactions with the ACEs and the ARBs you want to know about. Most of those interactions revolve around potassium. You want to watch serum potassium that goes up a little bit with the start of an ACE or an ARB. And so if you're giving anything else that's causing potassium to go up, including what we'll talk about in a bit, potassium-sparing diuretics, you want to be aware of that. Also, maybe it might affect lithium levels as it relates to salt and water accumulation, but usually otherwise not really meaningfully significant drug interactions. There are interactions, though, with grapefruit juice and some of the angiotensin receptor blockers, and so you'd want to be at least aware of that, particularly with losartan. So in a nutshell, the three major reasons you would not use an ACE or an ARB: renal artery stenosis, pregnancy, or allergy, particularly angioedema. For virtually every other patient, as long as the ACEs and ARBs could work, genetically there's not some predisposition of a problem, we're going to pick ACEs and ARBs as first line, particularly in folks with comorbid diabetes or heart failure. Okay, the last of the first-line therapies for hypertension are the calcium channel blockers, and in particular, the dihydropyridine calcium channel blockers. The dihydropyridine calcium channel blockers, their generic names end in IPINE, and of all of the agents you're going to see used for calcium channel blockers that are dihydropyridines that are used for hypertension, the one you'll see most often is amlodipine, or Norvasc, and they affect the influx of calcium channels into smooth vascular muscle, and so they're going to cause some modest vasodilation. They are effective for angina as well, but we don't usually use them for that alone. They are really first line for hypertension, and they're pretty well tolerated, and particularly in folks who don't respond to ACEs and ARBs that well, particularly African American or Black individuals. We will see that the dihydropyridine calcium channel blockers, particularly amlodipine, is a first-line therapy. The biggest downside to these agents is that doses above 10 milligrams of amlodipine classically cause a pretty high rate of pedal edema, peripheral edema in their ankles. And so that you lower the dose, it gets better. But anything more than 10 milligrams amlodipine, and that's a pretty common thing to see. There are other dihydropyridines as well. They're listed here, but again, the one you're more likely going to be seeing is amlodipine. You might see nicardipine in treating patients with very severe hypertension, but I'll tell you, other than that, you won't probably see most of these other drugs, other dihydropyridines. There are some subtle differences among them as well when we're comparing them as a class on contractility, cardiac contractility, vascular tone, and the like. But for the most part, amlodipine is the agent you'll see used. Let me briefly introduce the non-dihydropyridine calcium channel blockers. These work at different calcium channels, and these, while they will lower blood pressure, they are primarily going to slow conduction through the AV node. The earlier dihydropyridine agents we talked about have no effect on the AV node. These two do, diltiazem and verapamil. And where we're going to really use them is when we talk about cardiac arrhythmias, particularly atrial fibrillation. Particularly diltiazem really shines there. And we're going to come back and talk about diltiazem later on when we talk about its use in AFib, atrial fibrillation. These are some of the comparisons of diltiazem with verapamil, but again, not a focus here in hypertension. So this wraps up our first-line therapies for hypertension. We're going to go on to our second-line therapies in just a little bit. So let's go through now some of the drugs that are second line in hypertension. And because many of these drugs we're going to use in other cardiovascular circumstances, we'll talk about them here now because there are tools in your toolbox for other cardiovascular situations. But these agents are really not first line in hypertension. But we'll put them here so we have the toolbox as we go through the rest of the cardiovascular block. You'll see these agents come back again. First, let's keep in mind what those agents are. We have the loop diuretics or other diuretics other than thiazides as a second-line agent, beta blockers. We have the renin inhibitor, which we briefly talked about already. We have alpha blockers, both alpha-1 blockers and the centrally alpha-2 antagonists are the centrally acting drugs, and direct vasodilators. But all of these, because what makes these drugs second line is that despite the fact that they may all lower blood pressure, they haven't necessarily been correlated with improved outcomes overall. They haven't necessarily all demonstrated a reduction in heart attack and stroke, a reduction in renal failure, a reduction in other end organ damage or fatalities related to hypertension. And so these become second line because they're not as effective as other modalities at the important clinical outcomes related to hypertension. Let's look at the remaining diuretics here. We've already talked about the thiazide diuretics. First, the loop diuretics. The loops are mostly, in practice, the two you're going to see are furosemide and bumetanide. These are the two major oral and IV diuretics, and we mostly use them in heart failure. They're much more effective at getting fluid off. They can be given IV or orally, and we'll come back and talk more about them in the heart failure block. They work in the loop of Henle, That's the site of where they work in the nephron. They are most often used in heart failure. They may also be used in cirrhosis, particularly furosemide, in conjunction maybe with a potassium-sparing diuretic, spironolactone, in folks who have ascites or hepatic failure with ascites. We sometimes use them in renal disease with nephrotic syndrome. We could use them in hypertension, but they're second line. The big side effects with the loop diuretics are that they are more effective at getting fluid off, so the risk for dehydration is greater. They also may cause significant hypotension. We often will see a wasting of potassium and a loss of sodium and chloride as well. If they're given rapid IV push, they can cause ototoxicity. It's usually reversible, although ethacrynic acid, an older loop diuretic, that could be permanent, and we don't use that hardly at all anymore. And you might see changes in uric acid or in glycemic control as well, but not very often. The interactions with the loop diuretics, anything that affects potassium or sodium, we're going to be problematic with, so I'd encourage you to do a sort of interaction check there, but otherwise pretty well tolerated drugs. The potassium-sparing diuretics, there are a few listed here, but really the one to know and the one you're going to see in clinical practice is spironolactone. Spironolactone blocks aldosterone. It's not all that effective as a diuretic, but we're going to see that blunting aldosterone can be important when the patient is accumulating a lot of salt and water. And the scenario where that's most important is in heart failure and also in ascites in GI. We'll talk about those conditions more a little bit later. So while there are a few other potassium-sparing diuretics that are listed here, really spironolactone is the one you'll see used most often. And those work in the distal tubule. So important for us to sort of recognize that. Spironolactone really is your go-to drug usually here, and it does have a direct primary use in heart failure and also in ascites. Again, when we talk about each of those topics, heart failure in a couple of weeks and ascites in GI block, those are really where this drug shines. There also will have other side effects. Unlike the thiazides and the loop diuretics, spironolactone causes hyperkalemia. It may also be associated with gynecomastia. It seems to have an effect on prolactin levels to a degree, and so that could be a problem. And you need to watch for anything that could comorbidly cause an elevated potassium level, particularly ACE inhibitors or ARBs, which may be commonly used in either patients with hypertension or more commonly, that's a pretty common combination in heart failure patients. The other agent that's like spironolactone is Inspra. And I'll tell you quite honestly, I don't know that this agent has any advantage over spironolactone, except the disadvantage is it's more expensive. So, and there's less safety data on it because it hasn't been used as long-term as spironolactone. So I don't have a lot of experience with this agent, but I have not also seen it used in practice. The osmotic diuretics, for the sake of completeness, I'm including here. They osmotically draw fluid into the lumen, but we don't use them typically for hypertension. We most often use them to pull fluid out of fluid areas or keep fluids in the lumen of the nephron to prevent renal failure, for example, when we're giving nephrotoxic chemotherapy, and sometimes to reduce intraocular or intracranial pressure. The big agent here is probably mannitol. There are others as well, but that's the big one. And the osmotic diuretics work throughout the lumen really to draw fluid, like sugar, to draw fluid into the lumen. So they can be used, but not, in hypertension, we wouldn't use an osmotic diuretic. One of the next groups are the beta blockers. And the beta blockers are used for coronary artery disease. We're going to use them in heart failure. We'll talk about that, even though that seems counterintuitive initially. We will use them. But the beta blockers are not first line in hypertension because they are not associated alone without other comorbidities of reducing mortality or reducing stroke risk or development of kidney failure or other things that are problematic with hypertension. We alluded to beta blockers early on, and we're going to differentiate them by whether they block beta 1 receptors or beta 1 and beta 2 receptors or beta 1, beta 2, and alpha 1 receptors. The adverse effects of beta blockers depend on what receptors they work at, but they also will see, in addition to bradycardia, we may see other things like glucose intolerance, masking symptoms of hypoglycemia. If they're fat soluble, patients may also get a little depression associated with them. And if they start binding to beta 2 receptors, they conceivably could cause some bronchospasm. But we're going to see the primary differentiation among these agents is whether or not they bind to more than just the beta 1 receptors. The cardioselective or just beta 1 blockers, there are a number of them on the market. They're listed here. But the big two you really need to know of, metoprolol, which is the mainstay, main beta blocker you'll see, and also sometimes we'll see atenolol used. Not as much in the last decade, I think, as we used to see. The third cardioselective beta blocker that you will see in the hospital setting is esmolol, because it's an IV cardioselective beta blocker that has a very fast onset and short duration of action. And so esmolol might be used for tachyarrhythmias, maybe in the OR or in the ICU when somebody has got a rapid heart rate that you need to get down quickly. But the data for beta blockers as controlling blood pressure really is not used, because we'll see that other agents are better at reducing cardiovascular endpoints than beta blockers are. And so this earlier study in 2005, 2006 pretty much heralded the rendering of beta blockers as second line for hypertension. The beta 1 and beta 2 blockers, the ones that also block beta 2 receptors, include propranolol and nadolol and sotalol. And these each have other indications other than hypertension. Nadolol, primarily we're going to use this for portal hypertension. Propranolol, primarily for migraine headache prophylaxis, and sotalol for life-threatening ventricular arrhythmias. And they each have their role, but their roles, they will have added hypotension, so you have to watch their blood pressure when you add them, but you're not going to use any of these drugs primarily to control blood pressure as a first-line agent. And then the agents for alpha and beta blockers, the alpha 1 and beta 1, beta 2 blockers, you do need to know these two, both carvedilol and labetalol, and each of these drugs have a niche. Let me first go to labetalol, because labetalol is a first-line agent for hypertension in two populations. The first population is anybody with severe hypertension, where we have hypertension urgency or emergency. Labetalol, IV or oral, is often one of our first-line go-to drugs, because when we block alpha 1 receptors, we get a lot of vasodilation. The other place labetalol really fits is in women who are pregnant, that it is a pretty good track record of safety in women who are pregnant or childbearing age when you need hypertension control, blood pressure control. So labetalol is an agent that shines there. Carvedilol as an alpha 1 and beta 1, beta 2 blocker has an advantage really in heart failure. And metoprolol and carvedilol are really the two beta blockers you'll see most often used in heart failure. We'll talk much more about that then. But with either of these agents, you have to also think about you're also blocking beta 2 receptors, which if you have advanced COPD or asthma, at least in theory, could potentially pose a risk there. And so you need to watch for any worsening of those comorbidities if they happen. But as we talk about in the COPD block, in fact, the beta blockers, even the beta 2 blockers, may be not as risky as we once thought they were. As far as the renin inhibitors go, clinically not very often used. Let me briefly talk about this. Aliskiren, approved for over a decade as a direct renin inhibitor, might have a benefit in heart failure or hypertension, but the data's not there. It's not safe in pregnancy like ACEs and ARBs. Probably have all the risks of ACEs and ARBs, maybe even more so. Expensive, not a lot of experience with it clinically, not used very often in practice. I'll tell you quite honestly, I never see this drug being used. Let's go to the alpha-1 blockers. The alpha-1 blockers, dexazocin, prazosin, tamsulosin, or terazosin, these are going to clearly lower blood pressure. And in fact, the blood pressure drop is often dramatic on their first dose. Patients can often have dizziness or lethargy or fatigue. They can also have urinary incontinence changes. But the reason they're not first line, and even they're not even for many clinicians, even second line for blood pressure control, even though they're very good at lowering blood pressure, is because they don't have that outcome data for improving mortality and morbidity associated with hypertension. And so really, these drugs are limited to patients, older men with enlarged prostates, where they have a problem with urine stream. And we're sort of managing their blood pressure with the addition of this drug. But if they have hypertension, using this drug, is not preferable to using another drug which has good safety data in a first-line data agent. So we don't really recommend alpha-1 blockers even as second-line therapy unless we have comorbid enlarged prostates. The centrally acting agents, there are a few of them. We're really going to, but the centrally acting sympatholytic agents include methyl-dopa, clonidine, and two older agents, guanabens and guanfacine, and then some other agents that are really rarely used because of serious complications and side effects. But of these drugs, really the only one you'll see used frequently is clonidine. Methyl-dopa historically has been used because it's been safer in women who are pregnant, but really nobody uses methyl-dopa anymore because patients often have a lot of depression and cognitive impairment. Clonidine, though, is used pretty frequently, and not so much for blood pressure control, although we can add it on for a patient, and we'll see that done as like the third or fourth agent that's added on for blood pressure control. But clonidine also, because of its centrally acting action, helps symptoms of opioid withdrawal or alcohol withdrawal, where folks get tachycardic and get agitated and feel kind of like they want to jump out of their skin. Clonidine can help that. And so clonidine is often used for that. The problem with any of these agents, though, is that when you stop the drug quickly, you can get rebound hypertension. And so we'll sort of see that as a concern for any of them, but particularly with clonidine. And for these three agents, I could say the peripheral sympatholytic agents are really older. We don't use any of these drugs anymore. Really, they're associated with depression and significant orthostasis, lots of interactions. They really don't make sense to use. Some of the last groups of drugs we're going to talk about are the vasodilators. And for hypertension, they're not, again, first line, but let's talk through some of them. Each of these may have a certain niche, and we'll talk about where that niche is. First of all is nitroglycerin and the nitrates. They relax vascular smooth muscle. We're going to use them in angina, and we're going to use them when we need to have a pretty rapid drop in blood pressure. That might be somebody who's got a hypertensive crisis, but we're not going to use them really for hypotension very long. And the other problem with this, with nitroglycerin, is that you can develop after a couple of days, nitroglycerin won't work to lower your blood pressure anymore. And so we need to give drug-free intervals almost every day when someone's on nitroglycerin. But the other advantage, and we'll come back and talk about nitroglycerin, we sometimes use in heart failure when we want to reduce preload and afterload. And we'll talk more about that in heart failure and won't get into that right now. So nitroglycerin, we can use it for angina, and we still do, although not as often as we used to. We can use it for blood pressure manipulation, usually not directly for someone with hypertension, more often because we want to augment fluid shifts and maybe improve cardiac output for some other reason, but not all that commonly used. Nitroglycerin available IV, sublingual. There are some oral forms as well. We will find, though, that you have to use it carefully, and in patients who are on it more than 24 hours, we need to have what's called a nitrate-free interval because it results in depletion of sulfhydryl groups, and therefore you don't get the effectiveness of blood pressure lowering once you're on it for more than 24 hours at a time. There are lots of formulations: sublingual, oral, topical. There's a patch. There's a ointment. So lots of parenteral. The side effects big are orthostatic hypotension and headache. If the patient's not on a beta blocker, you may also get a reflex tachycardia. There are also some interactions you need to be aware of. The biggest one is with phosphodiesterase related agents used in either pulmonary hypertension or in erectile dysfunction, drugs like Viagra, sildenafil, where the blood pressure drop can be very dramatic and be a problem. Another vasodilator that you will see used as add-on therapy pretty commonly in the hospital, frankly, is hydralazine. Hydralazine is sort of like if you're on 3 drugs on board and the blood pressure is still really high, you may be seeing hydralazine added on. And so that's not uncommon to see that. We may see hydralazine also used in heart failure to affect preload and afterload. We'll talk more about that in heart failure. Orally absorbed pretty well, but also given parenterally, and we see it pretty commonly used. But any of the vasodilators can also cause a reflex tachycardia, so we want to be aware of that, and also headaches are not uncommon with agents like hydralazine. Longer-term use is not all that common, but when we need it long-term, we worry about lupus symptoms like developing joint pain, which is usually reversible when you stop the hydralazine. An older vasodilator that could be used, and rarely we'll see this one used, is minoxidil. Minoxidil, big vasodilator, but it causes a lot of reflex tachycardia associated with its use. But interesting, when the drug first came out, we found a lot of hair growth, and hence the real claim to fame for minoxidil is topical use for male pattern baldness and female pattern baldness. And then we alluded to earlier the vasodilators for pulmonary hypertension. They're listed here. If it's pulmonary hypertension, that's really usually managed by the pulmonologist. One other vasodilator I'm going to mention is nitroprusside. And nitroprusside is an older agent given IV in an ICU. It's like nitroglycerin, will cause dramatic vasodilation, but the problem is we worry about cyanide accumulation after 2 or 3 days of use. It's also become very expensive, interestingly, so not an agent we use that much. We used to use this in the ICU more often than we do now. The other vasodilators that we alluded to that are more aggressive, but are some of the calcium channel blockers, and nicardipine is the one I think of that is used for hypertensive crisis because of its complementary vasodilating properties as well. There are a few other drugs, cardiovascular drugs, that are used that could affect blood pressure but not used in hypertension. One of them is Ranexa, which I'll tell you honestly, I've only seen a couple of patients on. This is an agent that is used for coronary ischemia, although the data has not been very good for its use. It has some side effect profiles. It's not usually included in lots of protocols for coronary artery disease, but you may occasionally see a patient on it. The second drug, though, and we'll talk much more about this drug in heart failure management, is an neprilysin inhibitor. And this agent particularly is an enzyme. It works particularly inhibiting the enzyme responsible for atrial and brain natriuretic peptides, which ultimately, the use of this drug will decrease blood volume and blood pressure and is used primarily in heart failure. It will be associated actually with improved outcomes in heart failure. We don't use it for hypertension, but it may affect blood pressure, so you need to be kind of aware of that. So pretty much we've talked about all the drugs used in hypertension and having some other effects as well. And now let's look at hypertension guidelines and how we sort of navigate these tools in our toolbox for the patient in front of us. So a lot of what we've talked about, we've already gone through some of these slides from the AHA. I'm going to use The AHA is the framework for how we approach hypertension, but recognize there are other bodies or guidelines that are out there, and I'll allude to them occasionally and or talk about some individual scenarios that you might consider alternative than the standard approach. So the first thing we alluded to is what's your goal blood pressure? And for most patients, when are you going to treat? When are you going to add medicine? For patients who have an atherosclerotic risk factor of 10% or higher, or have clinical coronary vascular disease, those patients you want there, any blood pressure above 130/80, you're going to start treating it. And you're going to select your first line agent based on comorbidities or other conditions for that patient. For all other patients, if their risk factors are less than 10, our threshold for starting is 140/90. So I encourage you to go to some website on your phone and your mobile device and download the risk calculator, or go to online and look at this risk calculator and sort of manipulate the issues. This risk calculator is going to help estimate what is the 10-year coronary risk for the patient who's in front of you based on a number of variables, and we'll go through those. It's been pretty much validated, but it's pretty routine to do that, and you can download this on your phone. I will tell you that most clinicians in this day and age, when they do their annual physical for an adult patient, they're calculating this risk factor automatically, because these risk factors are going to help guide hypertension management, lipid management, and other cardiovascular disease risk management for the patient in front of you. The elements that are used in this risk factor estimator are the age, whether it's a male or female, what their ethnic or race background is, what their blood pressures are, what their cholesterol levels are, whether they've had diabetes, if they're a smoker or history of smoking, if they're already on hypertensive management, are they on a statin or not, are they on aspirin therapy, and all of those are going to then get sort of rolled into giving you a ballpark estimate for what their risk for a coronary event is over the next 10 years. And if their risk is greater than 10%, then we're going to go with the more aggressive management for blood pressure control. There are the recommendations we've talked about already. These are more or less what we call blood pressure control. I'm going to take just a minute here to diverge and let you know that in 2017, the AHA came up with their recommendations, and they're listed here in pink. And that's pretty much what we're going by. But I want you to be aware that the European Society of Cardiology came up with different guidelines and different recommendations for intervention, and those are listed in the light blue column here. And I don't want to belabor these, but they have sort of slightly different targets, and they also recommend starting folks on combination therapy instead of a single drug therapy, where that's a clear divergence from the guidelines from the AHA. So I want you to be aware there's European guidelines, but I want to tell you most clinicians probably in the U.S. don't use those European guidelines. So they're a little bit more at the divergence between them, but generally I think I'll sort of reiterate as we go through the AHA guidelines how most clinicians in practice are likely to approach it. So we've already seen this slide, basically what we're doing for interventions for each and workups for each of these categories of blood pressure control. We talked about the lifestyle and non-pharmacologic interventions for all patients. We looked at the reassessment checklist. And we already kind of looked at the thresholds and what we do. In clinical practice, we've already are looking at all of the risk factors for the patient in front of us, and those are going to influence our decisions and our goals and therapy. And some of this is already baked in to that 10-year cardiovascular risk factor estimate that we've already done. You want to, as we alluded to before, get rid of the things that will also contribute to raising blood pressure: recreational drugs, excessive alcohol, herbal supplements, and maybe nonsteroidals, amphetamines, estrogen-containing products, and the like. How often do you do follow-up with your patient? Depends on where they are in their blood pressure control. But typically, in most circumstances, for folks who aren't in very serious high blood pressure, you don't want to make changes too frequently unless they really have very high blood pressure. Typically, you're looking at an assessment every 1 to 3 months after they meet their blood pressure goal. But you probably want to look at monthly assessments until you get them in the control you want them to be. But unless they're urgently having a problem with their blood pressure control, you probably want to live with whatever last dose change you made with medicine. Look at them a month later before you start making more, because many of these antihypertensive drugs don't really kick into gear fully until a couple of weeks into therapy. We differentiated first and second line agents, so you should be familiar with those by now. Now, here's where we look at comorbidities and from the AHA, and they're kind of similar across the board. Let's look at these subgroup of patients, what our goals are, and when we're going to change therapy. So while we're looking at any patient for with their, if they have a coronary risk that is greater than 10% in 10 years, we're going to start treating them with a blood pressure of 130 over 80 or higher, otherwise 140 over 90. But if they have diabetes or chronic kidney disease or heart failure or ischemic heart disease, we're going to shoot for that lower threshold. Well, that's already baked into that atherosclerotic risk in 10 years. So yeah, we're going to really look at keeping their blood pressure below 130 over 80, excuse me. For stroke prevention, we're really going to do the same thing. But we will talk about, for folks who've had a recent stroke, we're not going to get too aggressive right after their stroke, and we'll talk about that near the end of this block. For Black Americans, we're going to look at using a thiazide and a calcium channel blocker, usually amlodipine, as our first choices. Why? Because ACEs and ARBs may not work as well genetically for them. And we're going to choose as our target, irrespective of their 10-year mortality rate, is probably a 130 over 80 as our point of achieving, keep harping on the drug and lifestyle changes until you reach that goal. Pregnant women, we're going to avoid ACEs and ARBs. We are probably going to use labetalol or maybe nifedipine or amlodipine. And for patients over the age of 65, we're going to probably start treating them to get their with their systolic pressures above 130. But with that cohort, I'll tell you honestly, we're also watching for orthostatic hypotension and falls risks. So all of the things that go through clinicians' minds, we've pretty much talked about all of them. So let's sort of look at this one more time. So you're going to pick your initial choices based on all the things we talked about. Now let's look at some comorbidities where other therapies are going to make sense. And some of these comorbidities we may have already talked about, or we talk about other points in the curriculum. If you have diabetes, you're a candidate for an ACE or an ARB and a calcium channel blocker or a thiazide. But an ACE or an ARB is your first line therapy, particularly if you have microalbuminuria, unless you have a contraindication to that, and that might be a woman of childbearing age or a history of angioedema, or renal artery stenosis. But if you have diabetes, unless there's a reason you shouldn't use it, ACEs and ARBs should be your first choice. Similarly, for chronic kidney diseases, ACEs or ARBs are your first choice. For a stroke or a TIA patient, ACEs or ARBs or a thiazide, any of them could be used as your first choice, but you've got to get their blood pressure in control. For coronary artery disease, in those cases, you're probably needing a beta blocker for their coronary artery disease. More on that later in this block, but you're going to add an ACE or an ARB to that. If they have reduced ejection fraction heart failure, again, an ACE or an ARB plus a beta blocker, and then you're going to look at sort of other modalities as it's tolerated. Aldosterone antagonist like spironolactone is going to be used if that fits in the guidelines. We'll talk more of those guidelines in heart failure. And if they have preserved ejection fraction heart failure, then we're going to use a diuretic and may not need any of those other things, although frankly, an ACE or an ARB is probably going to be added to that mix as well. So if you're clinically thinking through this, if you're thinking, how do these drugs work? What's the data for these drugs and how they work and what comorbidities there are? What's our goals? This should all begin to make sense. Which agents we're picking and why. And you do it in context for the patient in front of you, their genetic profile of likelihood, their history, their non-drug interventions you're doing, their comorbid states. All of that is related. Let's sort of wrap out hypertension with a couple of things. If you have hypertensive crisis or emergency, we have to be sort of seeing how we approach those circumstances. Those are different. Hypertensive emergency is, with a blood pressure greater than 180 over 120, and we're really going to consider that pretty aggressive management. And we're going to look at patients who have target end organ damage or not. If they have target end organ damage, early renal failure or something else, with that elevated blood pressure, we get more aggressive than in patients with a blood pressure 180 over 120 and don't have those outcomes. Our goals are going to be to get blood pressure down, but we want to be careful about not overdoing it because we want to maintain perfusion. Here is the algorithm from the AHA. You're going to look at, do they have target end organ damage with this elevated blood pressure? If they do, that's hypertensive emergency. You're going to admit them to the ICU, and you're going to look at other comorbid conditions and manage appropriately. If they don't have target organ damage, you might be able to get by with oral therapy, but you're probably going to do that in a somewhat controlled setting, whether you're going to have them be in the emergency department for a while or admit them to the floor, or you're going to make sure at the very least they're in a setting where they're monitored carefully. I'm not going to spend too much time going through the specific drugs for hypertensive emergencies. We've talked about most, but not all of them already, but they're sort of listed in this chart, and I encourage you to go through them. For hypertensive emergency with target organ damage already on board in the ICU, we could use nitroprusside, we could use nitroglycerin, we could use hydralazine IV. We could use an ACE inhibitor that's given IV. The only one is enalaprilat. We could use, although I don't see used, phenoldiprem. Nicardipine is the one I see used. Nicardipine drip used pretty frequently in settings I've been in. Or we could use clofidipine, which we haven't talked about. For other hypertensive emergencies, we could use esmolol, the beta blocker, or labetalol, and we do that pretty commonly, or perhaps phentolamine, which is infrequently used in hypertensive emergencies. If you have a hypertensive crisis or urgency and you have certain comorbidities, we sometimes look at certain agents having a better niche there. And so they're kind of listed here, but for folks who have a lot of sympathetic overdrive, maybe we're looking at an agent that may be more effective there. For intracranial hemorrhage, we're going to look at anything that's going to be continuous infusion that you can titrate easily, and that might be kind of nicardipine drip, or that might be nitroprusside, or that might be a nitroglycerin drip. If they have acute ischemic stroke, there isn't a particular preference, but with those, we want to be careful with stroke, either hemorrhagic or acute ischemic, that we don't lower blood pressure too much. Because in both acute intracranial hemorrhage and acute ischemic stroke, we don't want to overshoot our goal and affect reduced perfusion to the brain. Other issues we have for aortic dissection, coronary syndromes, we're going to look at specific agents based on how they present. Lastly, a couple of other issues, quick issues in hypertension management. Let's talk about these, are more recent. In mid-October, mid to late October 2019, lo and behold, we're getting ready to present, I'm getting ready to do this, and what I find the other day is that there is data to say that if you take your antihypertensive at bedtime as opposed to in the morning, there is a reduced risk for negative outcomes, and that bedtime should be the time you dose your daily antihypertensive. In fact, this is a fairly well-designed large trial, and the outcome measures for events of stroke, coronary events, cardiac events overall, or minor events, taking your dose at bedtime is better than taking it in the morning. And we have always known that many times coronary events, for example, are going to happen late or early, very early in the early morning hours. And so if your blood pressure controlled overnight is better, maybe that is associated with improved outcomes. But all of these issues, for the most part, are suggesting bedtime is better. Keep in mind, this is brand new data, so clinicians really haven't really digested this yet. And so people aren't routinely doing this, but you may see soon people looking at taking your meds at bedtime based on this fairly robust analysis. So the bottom line is, over years, treatment at bedtime compared to taking their antihypertensives in the morning, survival was dramatically better in the folks who took their meds at bedtime. And lo and behold, I think that's what you're going to see clinicians doing. A couple of last slides I want you to think about are sort of unique things that we've already alluded to, but let's talk about them. When you are going to avoid beta blockers? Well, you may want to avoid beta blockers in asthma, COPD. We talked a bit about that. But if you have a compelling indication for a beta blocker, again, probably not problematic, particularly if you're sticking with a cardioselective beta blocker. For diabetes, you want to avoid beta blockers as a rule. But if you have comorbid reason to give a beta blocker, I wouldn't hesitate to do that. If, however, you have a beta blocker on board, how patients monitor for hypoglycemia may be affected because the beta blockers will blunt tremors or sweating. And beta blockers in some cases affect sleep patterns and depression, but clinically usually not that important. Thiazides are going to worry most about gout, maybe diabetes risk, but that data is very soft. We don't usually use thiazides as our first line with diabetes anyway. We're going to usually use an ACE or an ARB if we can. ACEs and ARBs, we've already talked about who you're avoiding. Pregnancy, childbearing age, renal artery stenosis, and then you're paying attention to hyperkalemia and acute kidney injury, so we're going to worry or watch those situations with an ACE or an ARB. If you've got somebody with coronary artery disease, you're going to watch for reflex tachycardia with a vasodilator, particularly if they're not on a beta blocker. For older folks, we're watching for orthostatic hypotension, and we're titrating our doses carefully. We're watching for falls. For Black individuals, beta blockers and ACE inhibitors may not be as effective. We're looking at thiazides and calcium channel blockers as usually our first line there. In pregnancy, labetalol, maybe hydralazine is what I see clinicians using, avoiding ACEs and ARBs. Adherence is a big issue for patients. You want to be careful about orthostatic hypotension. We talked about the times you want to be careful for patients with dizziness and orthostasis. You want to look at their over-the-counter meds. You want to look at things they want to avoid. And one non-drug thing, actually, I'll talk about that I'll mention in passing that's associated with hypertension is black licorice. Black licorice actually, in a fair number of patients, causes accumulation of aldosterone, salt, and water, and actually can cause hypertension and fluid accumulation. So that's something, as a discussion for patients, you probably want to look at avoiding. There might be some pharmacogenetic variation among the drugs we use in cardiovascular medicine. Some of those are listed here. The ACE and ARBs, there's some subtle difference. And I think the big issue there, genetically, we see, particularly for Black Americans, avoiding ACEs and ARBs as a first-line agent for them because they're probably less effective. So we've already talked about that risk-benefit for ACEs and ARBs. There may also be a genetic variation in the risk for angioedema and or cough as well. When patients don't respond to therapy, their blood pressure isn't where you want them, typically you want to check with them about adherence, whether they're having hypertension, fluid overload, and whether they have pseudohypertension, and all of those are things you're going to look at.
Let's look at some supplemental content as of late 2023. There was published in late August of 2023, the AHA and the ACC combined with other professional organizations and published in the American College of Cardiology guideline updates for the management of patients with chronic coronary disease. And these provide in a sense, a summary of a number of overlapping guidelines. Virtually all of these recommendations that are posted here are consistent with everything that's been presented through this management of hypertension so far, but I thought it was just helpful just to reiterate that these are still considered current and appropriate guidelines. So at the end of each of these cardiovascular presentations, we'll do a very quick update on the 2023, late August 2023 updates from the AHA and ACC regarding where we stand with guidelines as it relates to the topic of that discussion. In the set of guidelines, they review both their strength of their recommendations and their level of evidence that supports that. And you could see that in the color coding system that's here, where green is the strongest of recommendations and red is actually a indicator of potential harm or at least lack of benefit in an orange red. And then the darker the blue color is, the higher that level of evidence is. This document reiterates the importance of non-pharmacologic strategies in managing blood pressure, including weight loss, healthy diet, reduction of sodium intake, physical activity, and moderation of alcohol intake. They also recommended enhancing intake of dietary potassium. That makes sense for a non-pharmacologic mechanism in someone who A, doesn't have elevated potassium, and B, is not on concurrent therapy with an ACE, an ARB, or a mineralocorticoid agonist like aldosterone, agonist like spironolactone. So you would not want to necessarily make a recommendation for increasing potassium intake if somebody's on an ACE, an ARB, or spironolactone. We'll reiterate that as well later on. But if they're not on one of those agents yet, then you might want to consider that as a possibility. It's just difficult to when you recommend that, if then somebody goes out and buys a over-the-counter potassium supplement, which there are some inadvertently as like salt substitutes or something, you want to be careful that they don't end up with hyperkalemia, which could also be dangerous. They have a number of recommendations here. Their strongest recommendations are in recommending weight management and then looking at pretty high up the role of GLP-1s, maybe SGLT2 agents as part of the management in patients who are overweight as part of their risks for coronary events or major adverse cardiac events. We also have recommendations that are a bit more specific about physical activity, including strong recommendations for both aerobic exercise and strength training or resistance training exercises. Both of those are pretty strong recommendations, and also lower intensity lifestyle activities that have a moderately strong recommendation as well. Their latest recommendations about smoking cessation are listed here. You could review those, but really doing everything you can to help patients quit smoking. The issue is avoiding secondhand smoke. And they are a little less strong in their recommendations for e-cigarette nicotine replacement as part of smoking cessation. They kind of indicate there isn't as great long-term data on that, so I think we're still waiting for the role of that. I think the other concern we have with e-cigarette smoking as opposed to standard smoking is that often the nicotine dosing that patients receive is often considerably higher with e-cigarettes than they are with standard cigarettes. So there's a lot of controversy about that role there of substituting e-cigarettes for standard tobacco smoke. They also review a number of resources that are available for smoking cessation. You could look at this, or I've also put this entire guideline published in Canvas as well. As far as recommendations for blood pressure management, they typically look at folks being in the 120 to 129 over 80 range or lower. I think what we see as clinicians is, you could go lower than 120 over 80 for a number of patients. What you begin to worry about is when their pressures get to the point where they have orthostatic hypotension, particularly in patients who are at risk for falls or fractures. That's often patients who have an underlying gait limitation or ambulation limitation to start with. That's often older patients who might have changes in bone density that increase the risk for a fracture secondary to falls. So all of that is in the mix of your decision of what's a reasonable blood pressure goal to achieve. They have recommendations for ACE and ARBs, which pretty much is strong recommendations for patients who have diabetes, who have reduced left ventricular ejection fraction, or have a chronic kidney disease. Those are the strongest recommendations. In patients without those comorbidities or diabetes, they still recommend them as an important avenue, but not quite as strongly as patients who have diabetes, hypertension, reduced ejection fractions, or chronic kidney disease. For beta blockers, they do recommend beta blockers. We'll talk more about this later on in patients who have heart failure, who've had a previous MI. And for those individuals, beta blockers have a good track record at reducing morbidity and mortality. But as you go to the bottom, number 4 here, if you don't have those comorbidities, there's really not a benefit at reducing major acute coronary events, MACE. And so as we've alluded to, beta blockers are not a first line for hypertension in patients who don't have those comorbidities. For immunizations, strong recommendations for influenza vaccine, also strong recommendation for COVID vaccine, slightly less strong recommendation for pneumococcal vaccine as well. The role of SGLT2s and GLP-1s are strong for patients who have diabetes already. They also talk about GLP-1s and SGLT2s offering cardiovascular benefit, perhaps independent of, or at least in conjunction with type 2 diabetes. That recommendation, if you have type 2 diabetes and a higher risk for coronary events, then you are a candidate for an SGLT2, GLP-1, or both. And so that's an important recommendation. They also will have some recommendations as it relates to weight management as it relates particularly to GLP-1 receptor agonists. And finally, in this document is a list of agents that are safe or safer in pregnancy and lactation. And the big 3 you see listed here for safety in pregnancy are labetalol, nifedipine, and the older Aldomet or alpha methyl-dopa, which, while it has been tried and true decades ago, because of the side effects of methyl-dopa, it is rarely seen as a commonly used agent. And then there are recommendations that are some limitations for some other treatment options that could be used in patients we've talked about, noticing on the right-hand column, ACEs and ARBs, aldosterone antagonists are considered contraindicated in pregnancy and probably risky in women who are lactating as well. Finally, at the end of each block, we have some of the more common agents that you might want to have familiarity with when you get to your clinical rotation, where you'd recognize what the typical doses are. We don't focus on dosing so much, again, in the exams and the therapeutics blocks, unless we've really stressed that in class. But when you get to your clinical rotations, many clinicians would expect that you'd have some familiarity with these.